Yeah, so thanks to Cure Cancer for giving me the opportunity to talk today and for funding this research. It's really a new sort of line of research for us, and so I'm going to give you a bit of background on the work we've done so far and where we want to take it. And that is towards using mRNA therapeutics to really modulate the tumor microenvironment to improve responses for pediatric sarcoma. So I'll just start by saying that the incidence of pediatric cancers is really very different to what we see in adult cancers, where things like lung cancer, breast cancer, melanoma are really common. In pediatric cancer, really the majority of cancers are either cancers like leukemia and lymphoma of the blood system or CNS brain tumors. However, sarcomas, there are a number of different subtypes, but as a whole, they do make up the third most common group of pediatric cancers. And in kids, we're really looking at bone sarcomas, so Ewing sarcoma and osteosarcoma, and then the soft tissue sarcomas, of which we're particularly interested in the rhabdomyosarcomas, which form within the growing long muscles of the limbs in kids. So it's important to really state upfront that we still don't have great treatments for kids with sarcoma. 1 in 3 kids will still die as a result of their sarcoma. So there's a real need to come up with better therapies, which I think has been a real focus of today's talks. So again, conventional cancer therapies like radiation therapy, chemotherapy, and particularly surgery have been the mainstay of cancer therapy. And this is similar in pediatrics as it is in adult cancer settings. Particularly in sarcomas, the first line of sort of treatment is often surgery to remove a lump or a bump that's found somewhere on a child's body. And then, depending on how confident the surgeon can be in the removal of that cancer, often chemotherapy or radiation therapy are given as follow-up. But these can have really devastating and long-term impacts on the health and well-being of these kids as they go on and develop. So, despite all this treatment, really high, there are high rates of relapse. For kids with sarcoma, and this remains a big problem because these cancers come back more aggressive and harder to treat when they do relapse. So we've heard a lot about immunotherapy. I'll just say that yes, it has become now a fourth pillar of cancer therapy in adults. When we look at some meta-analysis data of adult melanoma studies, you can see that the developments in immunotherapy have really pushed forward survival rates and had some really great outcomes in settings of really hard to treat and refractory cancers. However, that promise of immunotherapy is really yet to be translated to pediatric cancers and the pediatric setting. So overall, our kids don't respond as well to immunotherapy, and the responses that we do see are highly variable. So in pediatric soft tissue sarcoma, the response rates in a recent publication have been stated as less than 5%. So it's really clear that we need to do something to really bring that benefit that we're seeing in the adult setting for immunotherapy through to our kids as well. So one of the reasons, and we've heard a bit about mutational burden in some of the previous talks, is that these pediatric cancers haven't had a life course really to develop all these mutations that can lead to cancer. And so pediatric cancers often arise for different reasons than adult cancers. But one of the common factors that we do see is that they develop this suppressive tumor microenvironment that is really refractory to infiltration by immune cells, and then the immune cells that do get in there aren't properly activated, they don't have proper function, and they're not able to do their job. So our approach has really been to look at targeting this local tumor microenvironment. If you want to use the analogy to turn cold tumors into hot tumors, to see if we can push the response rates to immunotherapy to get response rates to immunotherapy to be higher. So we're really interested in local immunotherapy because it gives us some real advantages when we apply therapy locally directly to the site where it needs to be. Like, we don't have to give it to the entire body. This allows us to use lower doses. Obviously, there's lower toxicity. There's fewer off-target or systemic effects from the therapy if it does have off-target effects. And we also get an improvement in our therapeutic profile and pharmacokinetics when we can target drugs to the tumor microenvironment itself. So we really came to sort of view this in solid cancers that to this point of view that surgery was a real window of opportunity for us to start to provide treatments directly where they're needed at the time where the tumor burden is really the minimum it's ever going to be. So the surgeons come in, they've removed as much of the cancer as they can. If, for whatever reason, there's unresectable or undetectable tumor that gets left behind, what can we do at this moment to really stop that relapse post-surgery or metastatic spread of disease? And that this is a real problem in sarcoma that we're hoping to address. So we've developed these surgical mouse models, which allow us to sort of model an incomplete resection of a cancer where we can remove a certain proportion. We can apply treatments at that moment. We can retain resected tumor as well for a later analysis. And then we can sort of follow up these mice and see if our interventions that we make at the time of surgery have been effective at improving their outcomes. Really, where this project has come from is that we wanted to develop a way to deliver therapies intraoperatively. And the way that we decided to do this was with a biodegradable biomaterial or a hydrogel that could be implanted by the surgeon at the time of surgery and would slowly release immunotherapy in that local environment to activate and polarize the tumor microenvironment. This is work that we published recently. This is what this gel sort of actually looks like. We tested a whole range of different parameters for these hydrogels that we were trying to make. And we made sure that we were talking with surgeons through the whole process to really design a product that was fit for their purpose in terms of application during cancer resection surgery. So if we look a little bit closer down the microscope, these gels kind of are very porous. They have long polymer chains which form these pores, and we can encapsulate drugs within those pores, or we can bind them onto the polymer backbone of the gel as well. So what we ended up with was a product that was biodegradable. It was safe for surgery. It could be loaded with immunotherapeutics that would be slowly released over time. And it had the right physical characteristics for a surgeon to apply during surgery. And this is some work we really collaborated with some materials chemists down at UWA who have some fantastic expertise in this area. So I realize I'm a little bit short on time, so I'm just going to run through this really quickly, but we could show that we got slow release of drug over about the period of 2 weeks post-surgery. So here we've implanted fluorescently labeled drug within the gel in mice and then track the release over time. And we could show in settings where we remove, do an incomplete resection on these tumors, so we leave a little bit of cancer behind. We know it will grow back in 90% of these cases, and we can see that when we actually add our gel, which is loaded with an immune adjuvant. Here we've used the drug poly-IC. We can get good clearance of that residual tumor, and these mice have long-term protection and immune memory, so very positive. Poly-IC actually works through this complex pathway, but its main role is to activate interferon signaling, as you might see in a viral infection. And we can see in these tumors, when they do go on to respond well to this therapy, that they're doing this. They're activating inflammatory responses and interferon responses within the tumor microenvironment. And this leads to the production of cytokines, which draws immune cells into these tumors. So this drug is taken up predominantly by myeloid cells within those tumor microenvironments. But what we find is that this intraoperative therapy is really able to remodel the tumor microenvironment into one that's much more permissive to immune infiltration and proper immune function. Really importantly, when we do these surgeries, we apply the gel and then we come in and give the standard of care sort of immunotherapy checkpoint blockades. We find that we're able to now polarize the tumor microenvironment in a way that these patients now respond really well to these checkpoint blockade immunotherapies in a setting where really doing either treatment, the gel by itself or checkpoint blockade by itself, just aren't effective. So this, we think, gives us a real rationale for the combination of an intraoperative therapy with systemic immune therapy like checkpoint blockade to really enhance response rates in populations where the baseline response is quite low. So I'll skip through this because I'm short on time, but we have done a canine clinical trial just to look at a more relevant surgical setting. Where we'd really like to take this is in targeting this complex tumor network that we know exists within these cancers. And we have, transcriptional data and sequencing data on this. moving away from using general sort of immune adjuvants and looking at more precision approaches. And we plan to do this by using mRNA. So with mRNA, basically you can build an mRNA molecule to encode protein. And when you deliver that mRNA locally, like into the tumor microenvironment, like we might do with this gel, the encoded proteins are expressed transiently within that local environment. And these could be cytokines, it could be immune activating receptors or transcription factors or signaling pathway intermediates. And this allows us to really precisely deliver signaling into the tumor microenvironment in a transient fashion that can start to trigger these changes in the tumor microenvironment. We are still looking at, in the first pass, targeting this interferon signaling pathway. And as you can see, there are a lot of potential targets that we can look at encoding with mRNA within that environment. So lots of things to look at. We have some preliminary data. This is just screening of in vitro in a cell-based model where we can read out interferon signaling and the strength of that signaling after we give a low level of stimulation. And so on the left panel, you can see that we're able to achieve increased expression of our protein of interest. I've blacked it out here, but it's an immune activating protein expressed by the cell. We can increase the expression of this protein with mRNA. And then when we come in and look at how sensitive that cell is to stimulation, we can see that we can get 10-fold increased activation of that interferon signaling pathway at the same low dose of drugs. So really positive in vitro data here, and we're going to screen through a lot more candidates. And then the next step is really to develop and optimize the gel to allow us to deliver that mRNA in vivo. So the take-home messages are we're focused on local immunotherapy and the tumor microenvironment in the surgical setting. We have a platform for biomaterial delivery of therapeutics locally during surgery, and we're looking at testing some of these next generation mRNA therapies that will allow us to really precisely target and activate pathways within the tumor microenvironment, which we think will lead to more responses to therapy. Really, the final goal is to develop methods to increase patient response so that kids can really see this benefit from immunotherapy that we're seeing in certain adult cancers. I'd like to thank my community members here. This is Tracy and her son Angus, and one of the dogs from our clinical trials, Maggie, and also everyone in my group. Thanks.